Hello, I'm Scott Carson, Director of the Monison Centre for Business Research in Healthcare. Just prior to the 2014 Queen's Health Policy Change Conference, I had the opportunity to sit down with three panelists from Australia. Steve Hamilton, President of the Australian Medical Association, Mick Reid, who is a Director of the Australian National Health Performance Authority and Principal of Michael Reid and Associates, and Dr. Justin Beilby, Executive Dean, Faculty of Health Sciences at the University of Adelaide. In 2013, Australia adopted a national primary care strategy. We talked about the political and policy challenges associated with bringing about this system-wide approach. In recounting the Australian experience, it became apparent that Canada has much to learn from Australia's journey. Here is a part of our discussion.
With the National Health and Hospital Reform Commission, and there was a couple of key ingredients to why we moved down the pathway looking at this integrated primary care and nationwide strategy. There was a political will, Prime Minister and a Health Minister, who definitely said they promised to make that change, and that was really quite crucial. There was an increasing realisation from the public side of things that the access was being compromised, the quality wasn't as good as it used to be, the workforce wasn't as happy, so a coalescence of community factors all came together at the same time. And thirdly, there was a nationwide approach to looking at the health system, so that we drew, submissions and people from across the country were able to comment. And then, probably very importantly, this commission affirmed the key role with primary healthcare in creating sustainable healthcare systems and the value of looking at that across the country at the same time. It was really quite an exciting stepwise progression that then grew into the National Health and the strategy, which I'll get Steve to comment about, because that's in essence grew out of the commission once we got that sort of that base and that foundation, that passion, the need for change together. It really was very exciting to be part of.
Very good. So Steve, maybe you could tell us a little bit about what the strategy contains.
Well, I guess the other part of that framework that led to the start of the strategy was actually a public conversation as well, that change was necessary. So it wasn't just the politicians, it wasn't just the health leaders. The population understood that the population was ageing, the costs were going up, that if we wanted to have sustainable healthcare costs in the future, then change was needed. So that was kind of part of the reason that Health and Hospital Reform Commission, which set up the framework for the strategy, worked. So it was a coalition of a whole lot of people, including the public, who were quite well informed. The primary healthcare strategy really grew out of the Health and Hospital Reform Commission. The need for change, the need for focusing on primary healthcare, the sorts of things that we know makes health systems more efficient. That we do need strong primary healthcare, but we need integrated care. We need to be able to bring in a whole team approach to care, and focusing on, the problem in healthcare, which is those at the pointy end of care, the ones with multiple comorbidities. We're getting better and better right around the world at keeping people alive, keeping them healthy. But we're now treating 4 and 5 chronic conditions in that part of the population. They're the group that are actually going into the hospital sector, causing the costs in the hospital sector. And in many cases, they've got preventable conditions that we could keep them out of hospital. So there was an agreement that we've got to produce a strategy to deal with that. And that's where all of the state governments, all of the state health ministers signed off at the same time, which committed them to work on that process. And I guess the process included bringing in all the stakeholders, bringing in the colleges, the AMA, the state and federal governments, all of whom were working together. So it was a unique opportunity to put it together. They didn't just look at healthcare, they looked at the social determinants, they looked at special population groups, the Aboriginal and Torres Strait Islanders, they looked at the migrant populations with special needs. They certainly looked at those high needs patients and the need for more coordination in that area. They also looked at the primary healthcare organisations that were, I guess, new and a change from the divisions of general practice that we had to look at population health in the non-hospital space. There's been some developments about those more recently, to work with the private and public hospitals to actually look at those people that do end up bouncing from primary care into secondary care, the expensive part of care, and focusing on that group.
So it sounds in a way like there was a coalescing of interests that seemed to be coming together at the same time. So Mick, is that in fact an accurate description, or were steps needed to bring about agreement and to...
So a few things just to reflect upon it. The initial impetus came from, not from a government in power, but an opposition. So the initial desire to have national reform was a statement by the opposition that if we get into power at a federal level, we will embark upon a look at our health system. So that's the first thing. It was the impetus came out of there. When they got into power, there were some passionate ministers and other people who were keen at a Prime Minister level and ministerial level to carry that through. When the first report came out, we have to remember that the Prime Minister at the time then largely turned it into a discussion around our hospital system and waiting times, etc., the same types of things that occur here. And so there was then there was an element that we need to refocus back on the primary care system as a major determinant of our hospital usage by the population and by the clinicians and by the commentators on health. So that led to the primary healthcare strategy. And that was because the states themselves largely fund the hospitals, whereas the Commonwealth in Australia largely fund primary care. And so the states were feeling that the Commonwealth was getting off the hook by not having a good look at primary care when there was a very close microscope turned on the public hospital system.
So was there a primary driver? Was it cost, or was it quality of care, or a combination of the two, or other things?
It was a combination of 4 or 5 or 6 different factors, which we've just described. So the political reality, the quality, the costs, the ageing, integrated care.
Right.
But Mick is also right, the issue of how you manage primary care when it sits across the jurisdictions between the state and the Commonwealth. The Commonwealth initially said in the 2008 Commission they were going to take over primary care, completely manage it. They backtracked quite quickly because that wasn't a particularly logical policy framework, because the regional flexibility you need in a region to manage the gaps and work locally shouldn't be lost in this discussion. But what I think we've gone to in Australia is a realisation, if you look at the whole of the country around mental health, or you look at around integrated care, there are lessons to be gained by comparing and contrasting across Australia, so which we're very comfortable to do. So the issue of what works in New South Wales might work just as well in South Australia. There's a sharing of expertise and skills as we move forward. And that's been one of the wins out of the primary healthcare strategy. We've been able to align mental health, for example, youth mental health, now has a national approach it's rolled out in a model called Headspace, which is beginning to roll out across the country through a primary care structure. But it's looked at from where do we best value that and where are the risks and the gaps for that.
One of the ways of having this conversation, which has occurred since then, which you don't have in Canada, which we have in Australia, is a forum of health ministers at a federal and provincial level who meet on a regular basis to an agenda. So the carriage of the reform has still been in a collaborative arrangement, perhaps until our last budget, in a collaborative arrangement between the states and the federal government. And so they have an agenda, regular meetings, a large support mechanism, equivalent meetings of the heads of governments of each state, the Director Generals, and that really has been a vehicle for reform carriage and reform discussion. And that has been a very powerful tool as to how to sustain the reform and to shape it and modify it as we go along.
How has the reform been managed? Has a new structure, a new administrative structure been created, or was one in existence being used differently for this purpose?
It was probably overbuilt at the start, so it was built through premiers and prime ministers, and then it got devolved back to health ministers and agencies. But each state, each province, has their own health reform group within their agency. At the national level, there's a strong health reform group, and they would look at different aspects of health reform, be it around pricing, performance, e-health, primary care, all those emergency department usage. So there is a reform grouping in each state and territory in Australia, and there's a lot of communication that takes place and monitoring of those reforms as we've taken them through.
And the structure below that is a model that developed called Medicare Locals, which is not a particularly innovative name, but it started to put an organised primary care structure in between what Mick's describing with the national framework. And that's going to be changed with the recent budget, but they're trying to standardise that linkage across primary care with the colleges, and importantly with workforce. They're beginning to talk about how you link workforce into regional planning. But most importantly for this is the Medicare locals align with the local hospital networks, which are part of the state or the provincial models. So there's beginning to be a dawning discussion about how you align hospital funding and state funding with Commonwealth funding to map the gaps and try and go to build a coalition of willing at a regional level. You can work together. So you work at a region but across Australia at the same time. So it's really there's a positiveness, an excitement about where Australia is trying to go at the moment.
Well, I guess the other thing that happened inside the hospitals is we've got activity-based funding, which has been introduced across the board, across the country. Now, the benefits of that really haven't shown up yet because it's only been very recent that we've started to be able to measure what we're doing in public hospitals. And that'll give us an opportunity to again, do a gap analysis, comparisons across states about what are we treating, how much of it are we treating, and are there opportunities that we can learn from that. Now, our e-health strategy, of course, built on a PCHR, Personally Controlled Electronic Health Record, very much in its infancy, but lots of potential. Now, we have a common way of describing medical conditions now. We have a common medicinist terminology, so when we call something one thing in one state, we're going to be able to know exactly what it is in another state and measure those sort of things. And we've got communication protocols, so we can actually send and receive information and be confident it's going to be received accurately. But it's really still in its infancy, and that's really going to help us once we can start to measure what we're doing both in primary care and in hospital care.
When you look back at the process of change that brought all this together, I mean, you've painted quite a good picture of kind of the coalescing of interests. Were there any large impediments? Were there any states, for example, that held up their hand and said, no, not us, or parts of the medical profession, or...
All of the above.
All of the above.
All of the above. So, so at all levels there have been impediments put in place, or people who brought barriers to this process, and still do on a regular basis. And we have states who are further away from the federal capital and really see themselves as being poorly treated in the fact of their distance, like Western Australia. We've seen elements of the federal government who didn't wish to see the spotlight turned back on the federal government as a result of things occurring in the states. And most recently we've had a shift in Australia to conservative governments, both at a federal level and a state level, which really has moved lurched almost away from a process of cooperative federalism. And the latest budget, which occurred only 2 days ago, is going to be viewed in time as probably something which will lessen the reform process which will occur in Australia in a cooperative way. But I think it's too early to judge that. But notwithstanding that, right at the start there was genuine agreement by the provinces and the federal government that this was a journey worth embarking upon.
Justin, anything to add?
I think the lurch backwards will be small. I think most of the people who can see the system where it needs to go in the next 5 or 10 years will want to go forward with reform. I don't think the reform agenda will stop. I think it will just be mellowed and pushed and pulled for a little while as we go forward. We have to build primary care, and we have to build a better relationship between the hospitals and primary care. And the ageing, the issue of the interface between that section is an area that Australians are very sensitive about. The emergency department attendances, if we can control that and control that interface, that may turn out to be a lever for the future. But the community, particularly as they age with a chronic illness, want to stay at home, and we have to manage them differently, which is probably going to force the reform process practically, and probably because but we've been set the tone to move forward in the right direction.
Just one thing, one of the big things which led to the reform was a discussion that there was cost shifting, Commonwealth laying monies onto the states and the states laying money onto the Commonwealth, which led to a them and us process. And certainly one of the aspects of the reform which has occurred is there's very much less discussion now around cost shifting because of the transparency in dollar flows, how the dollars flow in the system. So that issue of is the Commonwealth paying too much or is the states paying too much, and is the states doing things that's forcing monies to be now expended by the Commonwealth, was a key driver in it, in the cooperation which occurred.
Okay, so advice to Canada. There you go, Steve.
Look, I think it's really important that to involve the public. They need to be part of the conversation, that change is really important. I know that's a bit of a struggle to get that information out there, but the public were on board with the conversation that change needed to happen, that the costs were rising and we needed to do things in a different way. So that was very important. The profession was right behind that as well, which is also very important.
Lead up to an election is important for an opposition. A catastrophe is always good. A transparency around what the problem is good, and so constant comparison to US probably doesn't help you in your argument in Canada, but comparison to OECD does, so that transparency around it. Passionate ministers at both provincial and national level who wish to look at this in a cooperative way, and obviously the more aligned the politics of the provinces with the federal government at points in time is also important.
Justin?
That I would actually argue that getting the ministers to come together regularly, both the national and the provincial ministers, to actually meet, discuss issues would be one of the first steps to move forward to get an integrated vision for primary care. I think it's actually thought leaders in each of the provinces coming together. It's not just the bureaucrats or the management, it's getting the thought leaders who can see we have to reform. And thirdly, it's the early wins around reform. It's getting the things right that you do well. Some of the work we're doing around integrated care, some of the work we're doing around mental health, youth mental health in Australia, shows if you take a national approach, you can actually make a difference. And so they're the sort of the stories that will draw people into the discussion about looking at things differently. And the big thing that's surfacing in Australia is actually the link between aged care and primary care. And that's probably going to be the bit that will be the next story to deal with. I think that will drive more reform as we try and deal with the very frail 80-year-olds. And I think with a primary care partnership, I think that's one of the exciting parts as we try and break open that barrier as well.
Good. Well, gentlemen, that's fantastic. Thank you very much. So, Steve and Mick and Justin, great to have you here, and we'll look forward to a wonderful conference and to your session coming up tomorrow. Thank you very much.
Thanks.